Good morning, everyone. Thank you for joining us this Sunday. We're going to get started. So if you can please find yourself to your seats. Good morning again. My name is Dr. Rupa Dutt, and I serve as the Executive Director of Women in Global Health, and I'm really excited to be having this conversation with all of you as we open the World Health Summit. Particularly, today's conversation is going to be about gender equality within the global health workforce, particularly talking about addressing gender equity to strengthen health for all. We're discussing this today because a more gender equal and diverse health workforce at all levels will lead to stronger health systems and therefore better health for all. Women are often portrayed in global health as health service beneficiaries, which is correct. Women are important users of health and social care services, and health services must address the health needs and rights of women, girls, if they are to be not left behind. But what's often overlooked is how the role of women, as 70% of the health and social workforce, women are critical change agents and drivers of health systems. With a predicted shortfall of almost 18 million health workers by 2030, investing in the health and social workforce is investing in women's economic participation and empowerment. But although they are a majority of the health workers, they only hold 25% of senior roles in global health, mainly occupying low-status, lower-paid jobs. Some women are further disadvantaged on the basis of their race, class, or other social factors, and as a result, health systems are weakened by loss of talent and diverse perspectives. There will be significant gains from the participation of women at all levels in health and social care workforce. And this will be made by eliminating gender inequality, bias, and discrimination. And that's the conversation we're going to be having today. Women in Global Health has campaigned and written on this subject since the formation of our movement in 2015. I'm pleased to say that the Universal Health Coverage Political Declaration, which was passed at the high-level meeting of heads of states and government on universal health coverage, recognizes the urgency of the global health workforce shortage. This has been hard work done by many that you'll be hearing from today as well. The role of women in the health workforce has been acknowledged, and the urgent need to address all forms of gender inequity in the health workforce as a critical step to achieving UHC. This is the first time that commitments have been made at the political level, which gives added importance to our discussion today. We particularly say that there's a triple gender dividend when you invest in the health workforce. There's a health dividend, millions of jobs needed to meet the growing healthcare demands and demographic change will be filled. There's a gender equality dividend. Women will gain income, education, autonomy, lead to improvements in education, health, and other aspects of development. And finally, there's also a development dividend. New jobs will be created by fueling economic growth. And to hear directly more about this, it is with my great pleasure to introduce our first speaker, Mr. Jim Campbell, Director of Health Workforce at WHO, who will outline the investment case and highlight the gender transformative work WHO is doing. Please welcome him.
Thank you very much, Rupa. Good morning. Welcome on a Sunday. So no PowerPoint, just some remarks to keep you engaged. So Your Excellency, Vice President Costa Rica, Ambassador, Regional Director, Dr. Carissa Etienne, guests. A few points here. You've heard from Rupa. I just want to pick up on one of those immediately. In September, we had the high-level political declaration on universal health coverage. That was a milestone in terms of our global awareness and understanding of how to drive forward action on ensuring health for all. If you'd have suggested as little as 5 years ago, maybe in 10 years even more so, that we would have such political consensus around universal health coverage, many people would have questioned that. That is something to be celebrated in of itself. The evidence that's been brought forward in the last 5 years around UHC really helps enable that political consensus. And as Rupa mentioned, it gives particular acknowledgement of the challenge around the health workforce, where the global strategy on human resources for health from 2016 and the work of a high-level commission on health, employment, and economic growth, warned that the ambition of ensuring primary health care and universal health coverage by 2030 will be challenged because of some basic labor economics around need, supply, and demand. We also recognize that the vast majority of the workforce around the world are women. It is, in most economic sectors, women's participation is an average of 41%. In health and social care, it's almost 70%. So we are a sector that employs far more women and youth than any other. With the high-level declaration also came the launch of the Global Action Plan on SDG 3. This was supported by Germany, Norway, Ghana, and 12 of the principal organizations, agencies involved in global health. And it sets out a series of accelerators. The first of those accelerators on primary health care. And this is where the majority of the workforce internationally are working. The second is on financing. And it's here that we need to talk about what is our investment case. If you look at the investment needed for universal health coverage, we extend into billions and trillions of dollars. The largest element of that is the workforce. It's the people who provide health and social care. More than 40% of the cost across a study of 67 low and middle income countries is investing in the people. And that's a figure of the standard operating costs. You've then got to add in their education, which is often driven by ministries of education or vocational training needs. If you add that price in addition to the healthcare cost, our people that we need to deliver universal health coverage is somewhere between 60 to 70% of the cost of delivering universal health coverage. And that may seem high, but that's a typical standard in OECD countries, in high-income countries. In Canada, there was a publication just a couple of days ago suggesting that over $1.2 billion per year is spent in the Canadian health system on its workforce, approximately 70%. So how do we generate the investment in our workforce, and of which the majority are women? Part of that was the triple dividend that Rupert presented a moment ago. We know the impact of the sector on healthcare, but there are these other potential impacts on SDG 5, on SDG 4, on SDG 8, which are cross-sectoral. But we shouldn't stand on our laurels and just say this triple dividend is there, because the reality is, as you'll hear from the panel, as more evidence has been produced, whilst the 70% of the workforce are women, it's not necessarily that they are getting the best deal in every healthcare system. That there are major opportunities for improvement on the gender pay gap, on the occupational segregation, on the leadership opportunities, and on their general terms and conditions and lived experience at work, where we do see increasingly and worryingly more evidence around harassment, violence, and many other challenges to women in the workforce. So we have to change. The investment case clearly is there. And how might we change? One opportunity that WHO and partners are looking at is how do we link this agenda to the work around human capital. The World Bank last year launched a human capital initiative to invest in the education, health, and skills, which is what drives the SDGs at the end of the day, including the benefit of health coverage. The IMF has additionally launched this year a new strategy on social spending. And the International Monetary Fund is actually now recognizing that investing in our our education systems, our health systems, and our social protection systems is a particularly positive use of fiscal policy and fiscal strategy to drive economic development, social development, and others. And it's unusual that we've got these combination of opportunities. The political consensus on universal health coverage, the World Bank consensus on investing in education, health, and skills, and the International Monetary Fund consensus on health, education, and social protection. That consensus needs to be translated into action at the country level, linked to the evidence that you'll hear about some of the challenges around gender equality and gender equity in the workforce, and we need to see the uptake of gender transformative policies. Women in the workforce is where our battle for primary health care and for universal health coverage will be accelerated fastest. And indeed, at WHO, we've made a great effort in the last couple of years to support what Rupa was suggesting. Women are the agents of change. The largest part of our employment, but they're there providing healthcare to communities, taking on leadership roles, bringing new evidence to the table as researchers and scientists. It is not only the narrative that has been part of the last 15 years of global healthcare that women are vulnerable and denied access to healthcare. We need to put both together, agents of change with vulnerability, to achieve universal health coverage and turn this investment case into action. I look forward to some fantastic discussion as well. Thank you very much.
Thank you, Jim, for setting the scene for us. And we're going to be moving on to the next part of our panel. But I want to also just acknowledge Dean, Professor, Dr. Helen Beaujolais is the co-chair of this panel, and she will be introducing herself in a few moments. On the note of agents of change, it is very exciting to welcome Her Excellency, the Vice President of Costa Rica, Ms. Epsi Campbell-Barr. She will be speaking to us shortly about some remarks about Costa Rica, but some things I wanted to highlight about her own journey. She was previously the foreign minister for Costa Rica. She has given decades to working on women's empowerment and particularly looking at issues of race in Costa Rica and in the Afro-Caribbean region. So really bringing that intersectionality approach, so talking about gender and beyond that. So on that note, a warm welcome. She is going to be speaking in Spanish. We are going to be providing translation services by Ms. Shirley Brajano, who's sitting next to her. Thank you.
Good morning, everybody. Es un placer para mí hablarles a ustedes en nombre de mi país y contarles un poco la experiencia y la ruta para disminuir las brechas que enfrentan las mujeres en el sector salud.
Good morning. It's a pleasure to be here representing Costa Rica. Okay. I'm so sorry we had a technical difficulty. I didn't quite catch that part. I apologize. Okay, thank you.
Don't worry.
I can say it again.
Es un placer poder compartir la experiencia de Costa Rica sobre lo que enfrentamos relacionado con los desafíos de las mujeres en el sector salud, pero además desde una perspectiva de la multietnicidad.
So it's a pleasure to represent Costa Rica and discuss about the gaps within the health workforce.
Los trabajadores y trabajadoras del sector salud a nivel global representan el 6%. En Costa Rica, ya en los últimos años, representan el 55%.
So the workers of the health sector represent 6% of the total population.
In Costa Rica, representing the 55% of total workers in health sector. La segregación vertical que existe entre las mujeres y los hombres en ocupaciones y categorías profesionales tiene como origen un fuerte componente cultural que se ha inclinado tanto a las mujeres como a los hombres hacia una preparación fuertemente estereotipada.
So the vertical segregation or concentration between men and women in the health sector, it has a strong origin, cultural origin, and it's inclined by women as much as men in the preparation for this profession.
De esta forma, las mujeres se encuentran en aquellos empleos como una prolongación a las actividades de cuidado vinculadas al trabajo reproductivo.
So women find themselves in these positions of prolonged and traditional assignments, in which are linked to reproductive health or because of the reproductive assignment. And they're also found in the care of women, the socialization of minors, and the provision of nutrition.
Ya sabemos que el control del tiempo afecta muchísimo más a las mujeres que a los hombres, puesto que dedican una parte muy importante a las labores de cuidado, aun cuando éstas estén en el trabajo productivo.
So we know that the long control between men and women have represented women of 39.6% between women and also 32% in the case of men.
Si bien esta realidad tendríamos que verla en una perspectiva de cómo eso causa mayor sobrecarga de trabajo, mayor estrés y un mayor agotamiento.
So in the reality of the overwhelmment in work, the stress, and also
Las mujeres hoy en día se sienten más cómodas. Hoy ya sabemos que en el sector salud las mujeres se sienten mucho más cómodas recibiendo atención de sus iguales, de mujeres, por ejemplo, en servicios de ginecología y obstetricia, porque y estas han venido aumentando en el sector salud.
So many women today feel more comfortable receiving health services of gynecology and obstetricians, receiving health from or care from their same sex or same gender. Because of this, the number of OBGYNs however, the number of OBGYNs in the US are men. And however, even though this number is diminishing, the percentage of women in this profession has grown. In comparison to 1970, 7%, and today, 59%.
Sin embargo, los puestos de dirección que ocupan las mujeres siguen siendo muchísimo menores a los puestos que ocupan los hombres.
However, the percentage of men are still larger than the percentage of women.
Y la participación y el mayor nivel de mujeres educadas en las ciencias de la salud no ha representado una disminución de las brechas que enfrentan tanto a niveles salariales como en niveles de dirección, de todos los niveles de dirección.
So even though the percentage of women is still large in the health workforce, they're in all of sciences as well, it's still not represented enough. More men represent.
La diversidad, las condiciones de diversidad étnico, racial, son elementos también centrales para poder mirar de qué manera está afectando diferentemente los sesgos de género en las mujeres en el sector salud.
So between racial and ethnic issues, there's also, it's not representing the gaps with men and women.
En nuestra región tenemos el gusto de tener a la doctora Etienne como directora de la Organización Panamericana de la Salud, y desde allí no solamente se están impulsando políticas que tienen que ver con una lógica de etnicidad en la salud, sino que creemos que hay una gran oportunidad para una política, para impulsar políticas públicas de diversidad dentro del mismo sector salud. Que desde la Organización Panamericana de la Salud se están impulsando políticas de etnicidad.
So from the Pan American Health Organization, with the help of Dr. Edney, there has been a big push towards these issues.
Pero lo más importante es impulsar políticas dentro del sector salud para garantizar esa diversidad en los trabajadores de la salud.
So the most important issue is to make these changes within the organization in order to push these policies.
Los estudios que tenemos a la vista nos muestran que el conocimiento y el poder, la creatividad que se tiene cuando el equipo humano es diverso, no cabe la menor duda, puesto que estamos atendiendo una sociedad que también es diversa. Que nosotros estamos atendiendo, necesitamos tener recursos humanos diversos.
We need to have human resources, more diverse human resources,
Porque estamos atendiendo una población diversa.
because we are attending a population that is very diverse.
La exclusión y la subrepresentación de mujeres distorsiona el sesgo de desarrollo, pero también la calidad de los servicios de salud.
So there's a distortion between the representation of women, and then there's a bias between the development, and which this implies there's a differences in system with the opportunities of women, or less opportunities between women and men.
El Estado debe brindar también a las trabajadoras del sector salud opciones de cuidado y de horario para que las mujeres del sector salud puedan insertarse plenamente en los mercados de trabajo en igualdad de condiciones.
So in this state, we are able to, or the options of the care and the scheduling of care, that women in the health sector are able to enter into the workforce with the same conditions as men.
Para terminar, como vicepresidenta de Costa Rica, creo que uno de los temas más importantes es la política pública.
So as representative of Costa Rica, one of the most important issues is the health policies.
La discusión puede ser técnica, pero la única forma de modificar los patrones y las condiciones es a través de la política pública.
So the only way that we can reduce the gaps and to confront this is between or addressing women in the health sector.
Finalmente, mi intención de participar en este panel es establecer una alianza estratégica con la Organización Mundial de Salud y PAHO para que con el apoyo técnico podamos impulsar en nuestra región una política pionera de disminución de las brechas que enfrentan las mujeres en el sector salud.
So with the help of PAHO to confront these issues is to address the gaps between women and men.
Muchísimas gracias.
Thank you, Mrs. Vice President. So I am Dr. Hélène Boisjoli. I am the Dean at the Faculty of Medicine at Université de Montréal in Canada, and I would like to say a few words briefly before we begin the panel to share the view of educators in medicine and allied health professions. Because a few reflections from Canada going beyond gender into ethnic diversity in medical schools, and I'd like to show that some progress is being made. So a few numbers from Canada, where 80% of the healthcare workforce is female, but 90% of nurses are women, and 42% of physicians are women. However, Canadian health-related organizations are led mostly by men. 80% of managers in hospitals, medical schools, and colleges delivering licensing and accreditation are men in Canada. In science, 1/3 of health scientists applying to Canadian federal funding are female. And recent data show that men have a 1.6 times higher chance of getting funded. But progress is being made. I am the first female dean of medicine in our province in Canada. That province counts 4 medical schools with 200 years history. But I have been dean now for over 8 years, and we are now 4 women out of 17 deans in Canada. And the Royal College of Surgeons and Physicians of Canada is now led by a woman. But Canadian schools are now, and I will echo what was just said, is now moving beyond gender equality with color and ethnic background and diversity as a whole being an objective for student admission, and this is a criteria for accreditation. Also, and why is diversity so important when we admit students? Well, this diversity aims for health workers to mirror the diversity in the population. And with that, it brings cultural competencies for students and also eventually sustainable health care for the population. Our school was recently, with the efforts of faculty and students, the European Association for Medical Education, we were recognized with the Aspire recognition for social accountability. But we still have work to do. We are working right now aiming at admission of Indigenous students in our medical schools. And in Montreal, about between 12 and 15% of the population is of color. Among nurses, they are really numerous, but a small number among physicians. So this is the next piece of work for our medical school in Montreal. So enough said about Canada, and now let's move on to our panel. So first, our conversation will begin with Mwenya Kasonde, and I will just sit so we begin the conversation.
Testing.
Yes. So, Mwenya, you are co-chair of the Gender Equity Hub in the Global Health Workforce Network, a hub chaired together with WHO. Your group recently released a report called Diversity by Women, delivered by women but led by men, a gender and equity analysis of the global health workforce, and you also recently released a WHO labor analysis paper. I have 2 questions for you. Number 1, can you share with us key findings of this literature review?
Thank you so much. Good morning, everyone. And thanks again to Rupa and the team for organizing such an important discussion here this morning. I think it's great that we start the conference with women. It's a good way to start the day. And I recognize the presence of Your Excellency, Vice President of Costa Rica. So as mentioned, I co-chair the Gender Equity Hub at Women in Global Health. And it's great to have WHO here, of course, because it's always good to have the WHO's support in everything that we do. I was delighted to hear Your Excellency talk about the importance of policy, because truly policy is what's going to drive all these changes. It's great to have these conversations, and this is certainly where the change starts, by having these conversations. But at the end of the day, the end point really is to have a policy that's going to implement and effectuate these changes. So one of the first things that the Gender Equity Hub did when this started is to see what the situation was. What is the current situation as far as women in the global healthcare workforce? So we started by developing this paper. The paper is entitled Global Health, Delivered by Women, Led by Men. And I would encourage everybody here to look it up. It's a very, very interesting paper, and it's a very important read. My slides don't seem to be showing up, but I don't know if we want to. Okay, I can just read from here. That's fine. So the paper essentially analyzed over 170 pieces of literature around gender equity in the global health workforce. Something that I would quickly mention is that most of the literature, unfortunately, is from the global north. I originally come from Zambia, so I'm coming at it slightly from a southern, global south point of view. But the literature that was reviewed is really mostly from the global north, mostly from Anglophone-speaking countries and high-income countries, which is one of the things that we actually were particularly concerned about, because if we're talking about SDGs and if we're talking about achieving universal health coverage, a lot of the work, as you all know, is really going to be targeted at the global south, which is where a lot of the health workforce is lacking. Nonetheless, over 170 pieces of literature were studied and examined. Now, just again to talk a little bit more about the Gender Equity Hub, it was launched about 2 years ago, back in 2017, along with the WHO. And the aim here is to convene all stakeholders, so be it ministries of health, be it the WHO, be it the private sector, all relevant stakeholders, in supporting us all in implementing global health strategies. The aim is to advance knowledge, data, and research on gender and health workforce, and to develop tools to promote gender transformative approaches. So the current situation, as has been mentioned, a few different numbers have been mentioned this morning. We heard 80% from Canada. We heard different numbers from across the world. But generally, the number that we're using is about 70%. So women make up roughly 70% of the global healthcare workforce. And I was delighted to hear Jim mention the fact that healthcare is unique in the sense that women tend to lead the way in terms of healthcare workforce compared to other sectors. So women deliver health and social care to around 5 billion people worldwide. And another thing, again, to think about is that a lot of this care is unpaid. A lot of this care is unrecognized. So women tend to care for their families at home. Of course, we care for our children, also for elderly people at home. So around 5 billion people are being cared for by women worldwide. And that amounts to roughly about $3 trillion annually of contribution in the health and social care workforce. Half of it approximately is unpaid work. So why is this so important? Why do we need these policies? Why is gender transformative policy such an important topic and a topic that we decided to focus so much of our efforts on this morning? Well, Rupa spoke about the triple dividend, and I really think that's a very good way of summarizing it all. It comes down really to the triple dividend, achieving our SDGs, and of course achieving universal health coverage for all. So the Gender Equity Hub focuses on 4 different policy priority areas. And again, this is all a result of the research that was done while developing the paper, Global Health Delivered by Women, Led by Men. So 4 different policy areas are being focused on. The first is occupational segregation, and this is horizontal as well as vertical segregation. The second is decent work, free from bias, from sexual harassment, from discrimination, etc. Again, while looking at the literature, one of the things that we found was that certain things are just not talked about. Sexual harassment and gender pay gap are two of those things that are not talked about and are even less so written about. So that's also something that we found that was actually quite an interesting finding. Gender pay gap is another issue that we're trying to address, and leadership and governments, of course. We want to see more women leaders. So the key messages from the report is that women deliver global health and men lead it. I really think the title is just so fitting because it really is what happens at the end of the day. Women are delivering about 70% of the global health workforce, but they're not leading. They're just not sitting in those positions of leadership. Workplace gender bias and discrimination are systemic, so they go across the board. A lot of the work that women provide is unpaid and often unrecognized. Workplace violence and sexual harassment is very much real, and it's something that still needs to be talked about and looked into a little bit further. And occupational segregation by gender is deep and universal. Some of the gaps, again, most of the data was from the global north, which is unfortunate because a lot of the issues that we face actually pertain to the global south. So one of the things that we would like to implement is to see a lot more research coming from the global south. Also, there was limitations in methodology. Very few people adopt an intersectionality approach. So we talk about women, but what about the compound effect of women, gender, class, race, etc.? Some of the recommendations. The first is to recognize both paid and unpaid work. Women work, as mentioned earlier, a lot of the work that is done is being unpaid and unrecognized. And that's not just in the home, that's even in the communities. Coming from Zambia, a lot of the women workers are community health workers. And we don't even call them workers, we call them volunteers. We call them community health volunteers, because they're simply not being paid and they're not being recognized for their work, a lot of them. Gender transformative policies really need to create a decent work environment and opportunities for women to close that gender gap, especially in leadership and as far as pay is concerned. We've spoken about the triple dividend, and increasing women's pay empowers women and empowers their families, of course. Women now become breadwinners, and that empowers the family. Research needs to prioritize the global south as well as the global north. And there's also plans for a midterm review in order to make sure that we deliver on our actions by the aim is to deliver by 2021. So it was a very, very interesting paper indeed.
Thank you, Dr. Kasande. Perhaps briefly, a second question for you, and looking at the Global South, your previous role was Assistant Director of Global Health in Zambia. How do you see these realities reflected in your own country?
Absolutely, and that's one of the reasons why I'm so passionate about policies, because I just left my position as Assistant Director of Global Health at the Ministry of Health in Zambia. And again, a lot of my work was in implementing policies. We talk about this so much, but really the policy has to be implemented, and it has to be implemented from the inside. So Zambia is quite, I have to say, it's a very good place to be, and we've been very proactive in our work in the healthcare workforce. We recently passed the Nurses and Midwife Bill, which is a very, very important piece of legislation, because as mentioned, a lot of the health workforce is delivered by not just women, but by nurses. So one of the issues that we have, of course, in Zambia, and I'm sure a lot of you will kind of attest to this, is that we don't have enough qualified professionals, we don't have enough doctors. So many of our institutions are actually being manned by nurses. The nurses have been doing this work, not just not being recognized for it, but they've not been protected. There's been no legislation to protect them. They're prescribing medication, and essentially they've been doing it illegally because there's been no legislation around the issue. So we just, this year, just passed the Nurses and Midwives Bill, which protects nurses as they do their work, especially in the community and the more rural areas in the country. That's one of the positives. Some of the negatives I do have to mention is a lot of our policies, we have a human resources for health strategy, for example, which runs from 2018 to 2024, but gender isn't addressed in the strategy. So in as much as we recognize the need to have a human resources for health strategy, we haven't quite implemented gender policy specifically into that strategy documents. So these are some of the challenges, but nonetheless, we are making progress.
Great. And thank you, Moine. So I'd like to turn next to Christina Sherrod. Christina is the founding and managing director of Seek Development. Your consultancy focuses on the financing aspect. Particularly, you provide in-depth OECD donor analytics to the global development community. Can you share with us some of your insights on donor financing, especially for gender equality in the health workforce? And particularly, how do these align with the political commitments that are being made and the discussions on gender equality?
Thanks, Rupa, and good morning, everyone. Thanks for having me, and thank you for putting together this wonderful panel of amazing women. So great to be here. So as you said, Seek is a boutique strategy and organizational consulting group that's focused exclusively on global development and especially on health. And one of our areas of work is around the area of analyzing and understanding and providing information around financing flows from donor countries into specific sectors and to countries in order to understand and advocate for particular policy priorities. And that, by the way, since you're all here, there's a little stand out there at the entrance where our team is. It's a donor tracker stand. It's a platform that's free information for everyone who wants to advocate for international development financing, and you can find us there. I will talk indeed a little bit about some of the data underlying financing. And this picks up from the points that Jim made and also that you made around the fact that this will only happen if we have sufficient financing. And obviously the starting point is the countries themselves, but donors still have an important place in catalyzing financing for gender equality in the workforce. And so what we'll look at today a little bit is what do we know about how much money actually goes into gender equality in the workforce. The fact is we don't actually know enough, and I'll talk to you about what we know in a moment. This gets a bit techy, hence 3 slides, but I'll promise to try and make this understandable. So the source of financing for development and health, you'll all be familiar with this, is the OECD database. So donors report into that database what they are funding, where, for what purposes. And for a few years now, we have something that's called the Gender Equality Policy Marker, which is an important tool there, because what donors can do is that they say, okay, I'm funding project XYZ, and in that project, gender is either a principal goal, that's called the Gender Policy Marker 2, or it's a significant goal. So it actually incorporates gender dimension, even if it's not the primary goal. That's Gender Policy Marker 1. Or there's no focus on gender at all. So that's the first component that we take. And then we combine that with what the database calls the purpose codes. So if you're kind of going through everything that's in health there, you can look at different purpose codes. And there are proxies in there that you can distill out. Relating to health personnel development, medical education and training, very importantly, but large, health policy and administrative management. We just heard about the fact that policies are critical to this, and personnel development for population and reproductive health. So if you take that together, you look at all the projects, the financing that went into those areas, and you combine it with the gender marker, you arrive at some very, very crude, that's to say, estimates around how much money actually went into this area. And that is shown here. If you go, so we looked at 2009 to 2017, how has that funding developed? And if you look at 2017 compared to 2009, you do see, if you look at the entire size of the bars here, that funding has actually, that's gone into health equality in the workforce and into the health workforce overall has grown quite significantly. So in 2017, and that's the latest data available, right? So we're not looking, and there's always a time lag in here. We cannot yet see how recent commitments have actually translated into funding. So this is always time lag. But if you look at 2017 compared to 2009, workforce has gotten more emphasis, so 1.3 billion about. And within that, that's the green piece of the bar, gender focused projects have gone up. The light green is some connection to gender. The dark green is just a little bit, is the primary focus on gender. And what you see there, though, is that the primary focus on gender has actually stayed quite the same, right? So that tells you something. So we've grown overall in terms of gender-related projects, but primary focus on healthcare still stayed pretty much the same. Now, one more look at how is this funding driven, or who is driving that funding. The top 5 donors that are contributing to the workforce overall, and then to gender within that are the UK, Japan, the EU, Germany, and Canada. And then it really drops off. And what is interesting to note, we also looked at, okay, how about the US? How about France, who are very large donors in global public health? You actually see, you only see them in position 11, I think, for France, and position 20 for the US. So when it comes to advocating for the US, we're actually far below where potential might be. On the right, you then see a look at funding for workforce-related purpose codes. So what I talked about at the very beginning, if you're trying to break down where funding is going by priority, if you look at those 4 categories, you see that about $1 billion, so the largest piece of all of this is going into health policy and administrative management, and the rest into the other 3 areas. What that says, what is interesting about that is, given the focus on policy change, that actually seems interesting, right? Because if the money is actually really going into health policy and administrative management, there might be potential to really emphasize gender equality more strongly. But then we did a word search to actually look at how much, if you're breaking down this health policy administrative management buckets, how much do we actually see in terms of projects that seem to be related to workforce, and only about 10% actually was. So that again tells you something about the data being quite weak, and probably even within that column, only a minority of projects actually being related to workforce projects. So all of that to emphasize that while there is interesting developments and encouraging developments around workforce funding going up, and within that an emphasis on gender increasing, the data is still incredibly weak if you're trying to hold donors accountable. And so some of the recommendations should relate to actually making that more transparent so that one can advocate more effectively.
Fantastic, Christina. 10%. That's quite a low percentage. And what are your thoughts on how can we? One ask is to have more data, more transparency from the donors. But how else? What opportunities do you see to really drive gender transformative policy change for the health workforce? Anything else that we all should be looking at?
To my mind, there's 3, and they're quite simple. The first one really is we would want to try, again, if you're looking at these 3 top donors, and if you're looking at workforce funding that has gender as its principal goal, that's super low still. So part of the advocacy should really, really focus on ensuring that these donors, as the principal funders, but also others, increase their focus on projects or funding projects that really, really drive gender as an absolute priority, so that we see this portion go up. Secondly, I think it'll be really, really important for WHO, other partners, advocates in the space, to really push to ensure that funding, especially within that health policy and administrative management space, gets aligned with policy priorities. There's now a lot of evidence out there around what works, and so what needs to happen is that the financing that's going into this sector actually gets aligned with those policies. And right now, that's not, as I was just saying, that's not necessarily happening, nor do we know. And then the third one is around unpacking the data and getting more granular around the data, because only if we know what's actually flowing where, can we say, okay, it's aligned here, but it's not yet aligned here, you need to increase here. So the whole piece around possibly advocating even within an OECD DAC context around a workforce-related way of tracking funding, and then becoming a little bit more rigorous around how gender-related funding is tracked is super important, because the light blue around, okay, it's gender-related, we're funding some gender in here, that's a very soft marker. So one could get a little bit more robust around what does it actually mean if I'm funding or prioritizing gender.
Thank you, Christina. So now moving to the next generation who will be trying to do better on this. Dr. Kaylin Mathar, your role as the chair of the Youth Hub in the Global Health Workforce Network. This is a hub chaired together with WHO, is releasing a paper on the reflections of youth and the health workforce. Can you share with us key trends and recommendations from your youth perspective?
Perfect. Thank you very much. And thank you, Women in Global Health, and Dr. Dutt for having us here to bring in the youth perspective. So very briefly, the Youth Hub is actually looking at issues faced by students, early career professionals, and also newly qualified workers in the health and social care sector. So the report that Professor Boisjoli mentioned is actually called Youth and Decent Work in the Health and Social Care Sector, and stay tuned for the official launch of the report in January of the upcoming year. So why do we talk about youth in the context of the discussion on gender? So just a couple of numbers. Currently, we have 21.8% of young people around the world that are unemployed. And out of these 21%, we have about 77% of those are women who are not employed and who are not in educational or vocational training. So this is certainly a significant number. Additionally, we have young people filling out more and more of the health and social sector jobs. So between 2005 and 2015, we have 100% increase of youth contributing to new health jobs in Tanzania, 90% in Colombia. And the numbers are very, very different around the world, but they're all quite staggering. So most likely the next workforce, taking into account the number of 70% of women constituting the global health workforce currently, the next generation workforce is going to be young and is going to be female. This particular report, what we found is actually quite staggering. Gender was an overarching theme that related to every single aspect that we found. So many things have already been mentioned by colleagues prior to my talk. However, gender discrimination and occupational segregation start really early on, both in society, at admissions to universities, to different jobs, etc. So that is one particular aspect that is always worth highlighting. The other thing is violence, sexual harassment, bullying, etc. That was found to be in very staggering numbers, particularly among young health workers, as well as more so among women in youth in the health workforce. So the bullying and harassment, I see a lot of people who look quite senior in the room, that comes across professions, from senior folks, be it doctors, nurses, from all professions, and trickles downstream to students and newly qualified workers. So that is something that is always worth noting from our end. The other aspect is social security and earnings. Young people come out with significant student debt into the health workforce. And lastly, and it's still a very significant issue, in addition to the bullying and harassment, which certainly contribute, work-life balance or work-life integration now as the newly coined term, those are particularly important, and we see increasingly higher rates of burnout amongst young women entering the health workforce. So I would say that gender and age are two confounding factors and very complex determinants that we need to think about addressing together in a strategic alliance, as Her Excellency, Madam Vice President, mentioned in her speech as well. So I guess I'll stop here.
Okay, thank you. So briefly, do you have numbers regarding the retention of the health workforce because of burnout or other conditions?
Absolutely. So I will also mention the same disclaimer as Juan said before. Most of our data is from high-income countries, but also mostly from two professions, which is doctors and nurses. But we know that we have early attrition rates that are as high as 7% in the youth health workforce. And that is also particularly important when we are talking about burnout. So maybe I will mention just a small example that may speak to some of you. If you imagine a newly qualified female health worker who is entering the profession, so maybe entering a profession that she didn't really choose, but she had to enter, talking about occupational segregation that starts early on. Add to that daily violence, bullying, sexual harassment in the workplace, but also family responsibilities, child and elderly care at home. If you take all of these together, I think this is a recipe for burnout. So certainly something that, again, we need to keep in mind when we're discussing early attrition, also retention, in order to be able to fill the 18 million shortage of health workers that was mentioned by Jim initially. We really need to keep every single health worker, every single young woman in the health workforce. So we cannot afford to lose any. All of these, again, need to be addressed in conjunction, I would say.
Thank you, Dr. Mater. So we're actually going to continue our reflections, and we've heard the perspectives of such rich discussions. And I'd like to introduce Dr. Charlotte Rafsoum. Great. She currently serves as a global healthcare executive at KPMG, but previously was a technical expert doing extensive research with the Nursing Now campaign that works closely with the World Health Organization. Charlotte, you've done extensive research on health workers, especially nurses, with the next year being a very special year, the year of the nurse and midwives. Can you tell us a little bit more about some reflections from that perspective? And particularly, we know there is an 18 million health workforce shortage. Many of those jobs are going to be filled by nurses and midwives. There was a key report released by Nursing Now this year. It'd be great to get your reflections about that report and just some trends related to this. Thank you.
Thank you, Rupa. And I'm really glad you mentioned 2020 as the year of the nurse and the midwife. I think that's going to be a fantastic step for us for two reasons. I think, firstly, to draw attention to the huge amount of work that nurses and midwives do and contribute to healthcare globally. But secondly, to really highlight the extent to which the nursing profession is held back in many ways from contributing as much as they possibly can. I mean, if you consider the fact that 50% of our health workforce are nurses, and in some place they are the first health worker and sometimes the only health worker that patients will interact with, they deliver a lot of primary care, a lot of health promotion, a lot of disease prevention, and really they are ideally placed to deal with a lot of the health challenges that we're going to face in the coming years, such as the rising tide of NCDs. And I think that at the moment, for many reasons, nurses aren't fully able to deliver what they are capable of. And I think that's for all the reasons that have been mentioned on this stage already. We don't pay nurses well. They work in terrible conditions. They don't have the equipment they need to do their jobs. They're balancing a home life and a work life. They have two jobs. They don't have the same scope of practice legislation in different countries, and they lack opportunities to leadership opportunities. So what this report from the Nursing Now in conjunction with Johnson & Johnson and IntraHealth was trying to do was really dissect that relationship between gender and nursing and leadership, and wanted to look at two specific issues. Why is it that there are so many women in nursing but so few women in positions of leadership? and why there are so few nurses in the position of leadership in the wider health workforce. And I think the findings would be unsurprising to most nurses and frankly unsurprising to most women. I think that, the report found that nurses don't occupy so many positions in the wider health workforce because nursing has been stereotyped as a female profession, and it's seen as nurturing and caring. It's not seen as a naturally leading profession, and so nurses feel they're often overlooked for those leadership opportunities. And then secondly, the question of why so few women occupy leadership positions in nursing when it's a female-dominated profession. I think it's all of the reasons we've spoken about already. So they are cultural and structural barriers that occur both at work in terms of opportunities to practice, but also at home in terms of the balance of responsibilities towards their home life.
So on that note, if there was one gender transformative policy change that nurses and midwives would want to see at the global or national level, what would that be? I know that's a tough question, but if you could pick one.
I think it's really hard to choose one. I think that I do think you need the totality of them to really show that you value nursing as a profession. And if you show that you are valuing nursing as a profession, then you show that you are valuing women in society. I think if I had to choose one, I would probably choose leadership and giving women the opportunities to prove themselves. That's probably what I would choose.
Thank you so much for your contribution here. Now to Christiane Wiskow from the International Labour Office. You use the decent work framework for workers' rights, and it also recently passed a landmark convention in June speaking about harassment and violence. So please, first, can you tell us more about the decent work framework so we can all benefit from this?
Yes, good morning, everybody. Good morning. And thank you, Your Excellency, and everybody on the panel. I was very pleased to hear the word decent work very often. So let me perhaps explain a little bit what we understand under decent work. In a nutshell, you can say that it is productive work in conditions of freedom, equality, security, and human dignity. So decent work really sums up the aspirations of people pertaining to their working lives. All of us wish for opportunities of work that are productive, meaningful, and provide for a fair remuneration. That we have social protection for our families, prospects for personal development, but we also need freedom to express our concerns, to organize and participate in the decisions that affect our working lives. And the equality of opportunity and treatment for all women and men is crucial in all this. So the ILO has developed an agenda based on 4 strategic objectives, notably looking at job creation, rights at work, social protection, and social dialogue, with gender equality as a cross-cutting objective. In the health sector, decent work has a dual role. First, in recruitment and retention of a sustainable health workforce, attracting young people to the profession, encouraging them through quality jobs in staying where they are mostly needed. And the second role is really in providing decent work to ensure quality of care, because we know there is an influence of working conditions on the quality of care. People working in healthcare need good quality in working environments to be enabled to provide this quality care. So let me take a broader look into ILO policies on gender equality, if you allow. As you may know, our organization celebrates its centenary. It's an old lady. And in that context, the Global Commission on the Future of Work calls for a human-centered agenda for the future of work, placing people and the work they do at the center of economic and social policy and business practice. And the Commission also called for implementing a transformative and measurable agenda for gender equality. And we heard many of the elements here already in the contributions of my colleagues. So accordingly, the ILO this year adopted a centenary declaration and states to strengthen efforts in achieving gender equality at work through a transformative agenda with regular evaluation of progress. So accountability is very, very important here. That ensures equal opportunities, participation, and equal treatment, including equal remuneration for work of equal value between women and men. And you may know that one of the fundamental conventions that ILO has adopted is the Equal Pay Convention number 100. To enable a balanced sharing of family responsibilities, we have to acknowledge, and it was also mentioned here, that as the Commission puts it, the world of work starts at home. We need a more fair distribution of care work that is unpaid usually, and until now usually mainly done by women, as we heard very staggering figures. So we need a better balanced sharing of family responsibilities, and for that we need more public investment in care economy, in care services, and we also need some scope for better achieving family-work balance policies.
Thank you, Christiane. A second question for you. Can you, let's talk about violence and harassment, because ILO has developed a convention about this.
Yes, and thank you. This is really, the adoption of these instruments is really historic and groundbreaking. I cannot overemphasize that, because never before the right of everyone to a world of work free from violence and harassment has been articulated in an international treaty. You have it now, black on white. It's there in writing. And it has been a struggle to get there, but the two instruments, the convention and its accompanying recommendations, are very strong instruments, far-reaching, and they have some very groundbreaking aspects. So, for example, defining violence is always has a wide variety and blurring lines. So the conference decided to take a pragmatic approach, defining violence and harassment as one term, as a range of unacceptable behaviors and practices that aim at result in or are likely to result in physical, psychological, sexual, or economic harm. The convention takes also account of the fact that nowadays work does not always take place at a physical workplace. We have a broad scope of places where work is being carried out, including through work-related communications. Yeah, we all know about these shit storms and what can really be bothering to people. And a last aspect really is the convention's focus on inclusivity is very important here, because it has far-reaching scope on to whom it applies, and that is, it means everyone who works is protected, irrespective of contractual situation. It includes interns, job applicants, but also persons exercising the authority of employers. They are also working people. And it applies to both public-private, formal, informal economy, and of course, urban and rural areas.
Thank you.
Thank you, Christiana. And, you know, this particular declaration, as you said, is quite a historical moment, having this convention, and there's a lot of momentum behind it, and some say it's really also the fact that there's a Me Too conversation happening that helped create the platform. So thank you for sharing that, but I think also for the room to be aware that now there are multiple tools out there. We have and I like to carry the Universal Health Coverage Political Declaration. It's 11 pages. I hope you all have a copy or e-version of it, but you know, the convention from ILO, there's great momentum on gender transformative change. So I'd like to turn back to Her Excellency, the Vice President of Costa Rica, and being a woman that has had such a pioneering career, but more importantly, being in a top leadership role, how do you see women leaders and leaders in senior leadership role really driving gender transformative change for the health workforce? What opportunity do you see? We have the political declaration on UHC here, the convention, and many other great moments of momentum now. So how can someone in your position advance the cause?
One of the most important things is now we have a lot of women leading policies. That's one of the way that we have to use to put in the table the tools that we have, the treaties that we have, the convention, but also we have to make more alliances between public and private sector, between women's and men's in the organization, and also to educate in all the level in gender issues, because we have to take decision and make the decision as a reality in the workforce of health. And the science and the data that we have to use it, not only as an instrument of discussion, but also with an instrument to make the change in the reality that we are facing. And I think that in government, we have more and more people involved in gender issues. And that's not an issue only for women, that's an issue for men. And I think that discussion like that, we have to make it in our countries. We have to send the research that we have, to use it in the health sector in our countries.
Great, thank you. Helen, would you like to say a remark?
Yeah. So perhaps to summarize a few of the very important comments we have heard today. Probably next year or in the future, we will be talking not only about gender, but also about other diversity groups. I think the challenge worldwide is to have the right health professional at the right place for the right patient, and by doing so, eventually, regarding costs, that should, help making sure that each, in my country it's $1 or euro, is used best. And the equal pay for equal work is another very important topic here. I'd like to add that protecting the health workforce is certainly a challenge, and everywhere in the world. And as a dean, I am often concerned or called upon for issues about harassment, about
for our students, but also for nurses and doctors. So we really have to fight the current harassment on the workforce, which is a truly important issue. And as Her Excellency, the Vice President said, action is encouraged. All these papers show a lot of data, but now we need more action. There are already some, but we need more of this. Now to you, Rupa.
Great, thank you, Helen. So we're actually going to turn now to all of you in the room. Really great evidence presented here, call to action, tools shared. I'm actually going to first begin by asking, we have a guest, our regional director from PAHO, Dr. Chris Etienne, to make the first intervention. So I'd like to ask her to make the first intervention, particularly the challenge of how can we drive gender transformative policy in your region.
Thank you, and good morning. And let me thank the panelists for what has been some really very stimulating discussions and presentations. So I'm Chris Etienne. I'm the director of PAHO, and PAHO is the regional office for the Americas for the World Health Organization. And we have been engaged in policy development for gender equality. In 2004, when I was the assistant director at PAHO, we passed a gender equality policy. Member states of the region passed that agenda. However, our region culturally is a macho dominated region. But we are making strides. We are making strides both within countries, but also in the organization. 52% of our workforce is female. At our executive management level, 50% is female. We have more female representatives in the country offices than males. We have a gap, however, in our middle management, our Ds, and from our P5s. And we had a study to find out within the organization why. And most of it is women feel that they have a responsibility to their families, and they have great difficulty in continuing their own personal advancement because of their domestic responsibilities. And we have then to decide what do we do to positively influence this gap to help women to be able to take their rightful positions at the leadership level. I think having women as leaders is extremely important to opening those doors and to ensuring that women are encouraged to step up and walk into those leadership positions as well. So we need advocacy. We definitely need the public policy, but we need the watchdogs. We need civil society movements to continue to challenge governments to ensure that women are afforded those opportunities. And I think importantly, we need to work with our schools of public health, with our schools of medicine and nursing, that they also include leadership training in general training. Because leaders you used to think that they are born. But yes, they are born, but they have to be trained and given the opportunity to become leaders. So very, very important. This year in September, our member states also, they passed a plan of action for gender equality and further implementation of this. So I am very hopeful that we will see more and more leaders. Thank you, as women. Thank you.
Great. Thank you, Dr. Etienne. So clearly a call for collective action, alliances, watching what's happening. So again, want to create some space from the room. Any questions or reflections? Yes, I see a couple hands. I'm going to ask the young woman here if you can please, again, state your name and who you're with and your question brief as possible. Thank you.
Thank you. My name is Rawan Taha. I'm a dentist, and I'm with Multipod Mentoring today. My question is for Dr. Kasande. Next month, I'm starting a fellowship in Zambia with the UNDP as a governance advisor. And I understand that Zambia is a country that's very proactive in the healthcare field, as you've stated, passing a bill for nurses. I'm wondering if you have any advice for me as a young professional in the field to perhaps pass a bill for women working at home, especially middle-aged women taking care of their elderly parents or perhaps sick children, to get paid for their work, as this would counteract the problem of unemployment, gender equality, as well as increasing economic stability in the country. Thank you.
Excellent. Thank you for the question, and congratulations to you. And it sounds great, and the work that you're doing really sounds very, very interesting. As far as advice, my advice would be to, for lack of a better word, get your hands dirty, in the sense that really get out there, go into the communities, speak to the women. These are the frontline workers. In as much as it's great to sit in Parliament and pass bills, they really have to be reflective of the situation on the ground. And the only way to really get an idea of what's on the ground is to get there, to really go on the ground, get into the communities, get into the villages, speak to these women. You really learn so much from them.
Great, I see a hand up there. Let's see.
Yes.
Do we have any extra mics on the floor? Okay, great. Actually, Dr. Rana, and then we'll come back to the front.
Yes, I'm not sure. Is it working? Okay, great. Yes. Hi, thank you very much for a really stimulating discussion. My name is Rana Haji. I'm with the WHO Eastern Mediterranean Regional Office in Cairo, Egypt. And, I'm a health expert. I'm not a gender expert, but a couple of issues I noticed from the discussion, since we're all focusing on medical education and health. One issue for education, we have to start much earlier. We all know, we have studies that show that education of girls, even to the level of primary education, has significant impact on the health of their kids and their families. So I think as women, we really need to also be advocates for much earlier education of girls. In many parts of the world, including in our part of the world, in the Middle East, there are still many countries where girls' education is much lower than boys' education, and we need to really start earlier, because this will have impact on the health workforce later, especially many areas, in particular nursing. We are facing significant shortage of actual nurses. We have a lot more doctors, men and women, but we don't have enough nurses and other healthcare workers. The other issue in terms of, because I really appreciate what Dr. Etienne had mentioned, the WHO, I've seen a lot of developments recently in terms of awareness about the need for more gender equality, etc. But there's still some fundamental issues, and I will just use my own example. My kids were grown. I was working for the US CDC, very quickly, but yeah. I was interested in working for WHO. So I actually had to leave the US, my country. I'm Lebanese American. And I had to leave my husband there. I didn't leave my husband, thankfully. But, because at the time, WHO really does not have any program to help with spouse, positions, or at least arranging for spouses to even look for this. So if we are serious about empowering women to be more mid-level managers and higher, we really need to look more seriously at family arrangements. What can we do to help them? We're not going to favor their spouses, but what can we do to encourage them to be able to get to these positions without being afraid of breaking their families? Thank you.
Great. Thank you, Dr. Rana. So we have time for 2 more interventions. I'm going to be mindful, young woman here in the front, if you could state your name and where you're from. And I see a woman back there. Yeah, that one, yes. Go ahead, please.
Yeah. Hi, my name is Anushwara. I'm from India. I'm part of a social entrepreneurship organization that is creating healthcare access to women in India, to rural Indians. So I have a comment and a question. So regarding what Charlotte Refson mentioned about how the workforce is treated just as caregivers and not as leaders, for the past 2 years we have been running a program in various parts of rural India where we are trying to convert the healthcare workers who are female into entrepreneurs. Like we started with 2 nurses, and now we are in 200 nurses who are running clinics as a part of leadership program. It has been very challenging, but very rewarding. Now my question comes to Christina Sherrod. From the experience in the last 3 years, beyond a point, without investments, most of these programs are not possible to run in a sustainable manner. From your learnings and from what you have presented, how can we hold financing organizations accountable to make gender as a key focus of investment? How do we ensure that all of these studies create an accountability mechanism that will go into investment? And now we have impact investing and purpose-led investing. How do we do that?
Thank you. So your question about accountability. And then one last question, young woman right there. See how, you'll get it, Jen? Okay. Being mindful of time, I'm going to ask each of the panelists if they have want to reflect on any of these questions. So we'll begin on this side with Moene, okay? After this question.
Good morning, everybody. My name is Denise. I'm an independent consultant on human rights, currently based here in Berlin, but I'm originally from Brazil. I have a question, and during this panel, all your remarks were extremely interesting, and they show, I think they express part of the incremental change we've had in the past decades about more gender equality. But my question goes to Your Excellency, Ms. Campbell, but actually I would love to hear everybody in the panel. I guess it would not be possible. Regarding the backlashes that we are having in many countries, and I think my country is a very good example of that, in which gender equality is not anymore an unanimity, and far from that, we are having backlashes from speeches that would like to put women back in their traditional roles. So in that situation, the whole scene, the whole landscape of policy that is able to happen, and this is not something that is happening only in my country, it's happening in several other countries and in many regions, in every region in the world. So what are your comments about how to make everything, all the amazing recommendations that each one of you have given in political scenes where we are actually going backwards? So for just giving a very concrete example, one of the reports mentioned unpaid work for women. That's where we had to if this continues.
Yeah, I mean, these have been very interesting comments, and it's been a very rich discussion. And for me, this morning has just reflected the importance of having multiple stakeholders at the table. So we've got, of course, we've got the women here, the nurses, we've had entrepreneurs here, which is a very important part of the discussion, policymakers, the WHO, etc. I think really what the take-home is for me is having multiple stakeholders at the table. And I just want to comment once more on the triple dividend. Rupa mentioned it this morning, and for me that's really just such an important thing to think about. We're empowering women, but we're essentially getting better healthcare. We're getting closer to universal health coverage. We're getting better families, better nutrition, education in the home once women are empowered, and we're also, fostering economic development. So I think those are the two kind of closing comments from me.
Thanks, Moene. Christina?
Thanks. So the question was around how do you hold donors accountable? To my mind, just the lessons from global health over the last 15 years has shown pretty much 3 things. The first one, as I said earlier, it's getting the data, right? You can only hold donors accountable for what you can measure. So really digging into what is getting funded in relation to the global health workforce, how much focus there is on gender within that funding, and how well it is aligned with the policy priorities that are being outlined is critical. And right now, that database is still not good enough, right? So one of the priorities needs to be to really, really try and get a handle on what those financing flows look like. The second one then is clear, prioritized, and that's important, fundable priorities, right? So if I'm a Germany or if I'm a Canada or if I'm a US, what is being presented to me in terms of what I should do needs to be fundable. And there needs to be a clear connection with, if I fund this, what will be the benefit of that? And the WHO has done great work around that investment case and being really clear about, okay, you can do this, right? Because as a donor, I don't always know. If we're saying, okay, if you're funding, policy change, what exactly does that mean? And how do I do that? And what will it lead to? Because then you can not only say, look, funding is too low right now, we need to increase, but also here's how you do this. And then the third piece is around what we are doing today, which is why I'm so excited that we're here, right? It's about building a community, right? An advocacy, a community that spans the spectrum of northern civil society, very important southern civil society, governments, north and south, that actually is in that discourse and is starting to have a dialogue around this so that it hits the agenda and so that it is not okay to ignore the issue.
Thank you, Christina. Colleen?
Very quickly, maybe I'll answer to Dr. Haji's comments, since we both come from the same place, but not just for that. So with regards to supporting primary education for girls, this is absolutely a crucial element. We are talking about young professionals, students, etc., but also how do we get people to get there. Also maybe mentioning paying women for the caregiving that they do that goes unpaid, which is also a very big chunk of the current health workforce as well. Just maybe regarding the shortage of nurses, which is, and the having more doctors than nurses, which is certainly the case in EMRO, but I'm learning that is also the case in some countries in Eastern Europe, for example, in Georgia, where you have 2 doctors for 1 nurse. Maybe going back to the discussion about the Nursing Now report, elevating nursing as a profession, elevating health professions in general, elevating them equally, and making sure that nurses have decent work and decent pay could be a solution, in my opinion.
Great, thank you, Colleen. I'm going to turn to Charlotte.
Thank you. I just wanted to reflect on your question and comment and your experience in India and training nurses and health professionals there. I just think it's incredibly inspiring to hear what you've managed to achieve, and I think it just demonstrates what nurses and healthcare volunteers can do if you give them the opportunity. But I think we need to support that promise with professional regulation and a legal standpoint and education, these 3 things that you need together. You need to give them a professional scope of practice that's supported in professional regulation and in law and supported by education, all 3 of them together.
Thank you, Charlotte. Christiane?
Thank you very much for all your contributions, and I know there would be much more to discuss, and we hope to do so during the breaks. Allow me a very general comment here. If you want to get to people to change, if you want to get change, policy change, dare to speak up. Raise your voices. And this is not just for women, and I want to acknowledge all the men here in the room who made their way on a Sunday morning to listen to this topic. Speak up, and if you don't dare to speak up, get organized. As an organization, you have so much more power, and I'm not only talking about trade unions, but all sorts of organizations that bring forward with collective voices issues that need to be addressed urgently in policy life. Thank you.
Thank you. Her Excellency.
I want to add 2 things. The first one is in terms that we have to include the diversity perspective with gender in our work with the workforce of health. And in our region, we have a very large of Afro-descendant people, indigenous people, and all diverse identities that we have to face with. And that we cannot face gender issues without including diverse identities. This is one of the most important things. The second thing, that we as politics, we have to to work more and more in terms of public policies of care, to include women in equal situation that men. That one of the most important issue for empower women. Care issues is an issue of equality, not only equality in the work, but also equality in the private sector. In reproductive work, we have to include as government the faster and faster all the policies in terms of cares. I think that if we work in that arena, we can change a lot in terms of workforce.
Great, thank you.
I just want to make a comment on the backlash issue. I can say that I am observing this backlash, in Canada right now, and we are all women here. If we want to solve this, we need men to be engaged, and perhaps we could have a conversation, next year about this. So we will have to watch for a backlash and make sure that we don't lose too much terrain before it improves again.
Thank you, Helen, and it's been a pleasure to co-chair with you. And thank you to our esteemed panelists, speakers. It's been such a great discussion. Not only did we hear about evidence, the investment case, but also a strong call to action. So also want to acknowledge the World Health Summit for creating an opportunity to discuss this. And thank you to all of those that have stayed on a little bit extra into lunch. If you are interested in working on gender equity and health workforce issues with us, please join the Gender Equity Hub. The details are in the back. And again, thank you everyone for this wonderful discussion. But let's make sure it doesn't stop here and we drive real action where it matters most. Thank you.